Hello and welcome to another YouTube tutorial. My name is James Piper. I'm a Senior Fellow and Clinical Lecturer in Acute Medicine at the University College of London. And today I'm going to talk about acute PE, and the aim of this talk is primarily for Year 6 students, those studying for finals and those who want to brush up on the more advanced aspects of clinical care of patients with suspected pulmonary embolism. In this talk, I'm going to talk about the epidemiology of PE, predisposing factors, the assessment, management, and follow-up of PE. I'm going to try and focus on what exactly you need to know, the latest headlines and guidance, and I've taken for today's talk the European Society of Cardiology's guidance on pulmonary embolism as my source reference. So when we look at data, this is from the journal of the American Society of Cardiology, you can see that the mortality due to pulmonary embolism has steadily declined from about 1999 to the early 2000s. But you'll notice also that it is slowly on the increase again from around 2010. And I think partly this is because of the prevalence of older people is getting bigger. Women are having higher risk births or giving birth later than they previously did, and people are living with more multiple comorbidities. So therefore the risk of developing pulmonary embolism is now starting to increase again. Although technology in healthcare has improved, medical risks have increased. So VTE or DVT-PE is the third most frequent acute cardiovascular syndrome after stroke and myocardial infarction. The annual incidence of PE is about 39 to 115 per 100,000 of the population. What's important to note is that the incidence of VTE is nearly 8 times higher in those aged 80 and above than those aged 50, so there is a significant exponentially rising gap in those getting old. The treatment of VTE, however, is extremely expensive, and all types of VTE has been estimated to cost about $8.5 billion in the EU. In European studies, about 35% of patients had died acutely or within a few hours of the acute VTE. So this is important to realise that it can have significant catastrophic consequences, and these patients do present unwell and are a serious medical emergency that needs treating. When we look further at the age group, you can see that the incidence of VTE, as I was saying earlier, rises significantly from the age of 50, and you'll notice that both the incidence of DVT and PEs rise as well, and the link to that particular paper is on the slide here. So when we're thinking about risk assessment of PE, we have to think about two types of factors. And the first ones are patient-related factors, and these tend to be permanent. So, for example, comorbid disease, age, level of mobility, and so on. Now, setting-related factors, so these tend to be temporary. So it might be that the patient is having chemotherapy. It might be the patient has had cancer and is awaiting cancer surgery for curative intent. It might be that the patient has broken their ankle and so has limited mobility, or they're having an orthopedic operation. So very often there is an overlap between these two, which then gives you the risk of developing PE. So we're now going to talk about some of the different strengths of provoking factors. So these are factors in which you should be paying particular attention to for the development of pulmonary embolism, and these include fracture of a lower limb, admission for heart failure or atrial fibrillation within the past 3 months, hip or knee replacement, major trauma, myocardial infarction within the past 3 months, previous VTE, and spinal cord injury. Moderate risk factors are more numerous, and these include arthroscopic knee surgery, autoimmune diseases, blood transfusion, central venous catheter lines, intravenous catheters and leads, chemotherapy, CCF or respiratory failure, EPO-stimulating agents, postpartum period, infections such as pneumonia, UTI, and HIV, inflammatory bowel disease, metastatic cancer, paralytic stroke, superficial vein thrombosis, thrombophilia, in vitro fertilization, and the use of HRT or the oral contraceptive pill. Weaker risk factors include bed rest of greater than 3 days, diabetes mellitus, arterial hypertension, immobility such as prolonged car or air travel, and this particularly should be at least over 4 hours to be considered prolonged, increasing age, laparoscopic surgery, obesity, pregnancy, and varicose veins. So PE is often seen in patients who have cancers, and these are the most highest risk cancers for the development of pulmonary embolism, and these include pancreatic cancer, the hematological malignancies, lung cancer, gastric cancer, and brain tumours. So what is the pathophysiology of PE? Well, acute PE interferes with both the circulation and the gas exchange, and then what happens is that you start to develop right ventricular failure due to acute pressure overload of the heart, and this is the primary cause of death in acute PE. You also have anatomical obstruction and hypoxic vasoconstriction in the affected lung area, which then in turn causes an increase in the pulmonary vascular resistance, which then in turn causes right ventricular dilatation. And this is sort of known as a spiral of death for the pathophysiology of PE. This then further causes pressure on the intraventricular septum, causing desynchronization of the ventricles and ultimately cardiac arrest. And this is a diagram here to explain what I've just said in picture form. So you have the increased right ventricular afterload, which then causes right ventricular dilatation and tricuspid valve insufficiency, and then it sets off a numeral myocardial inflammatory response, increases ventricular demand, causing ischemia, and then eventually you'll have reduced right ventricular output, reduced left ventricular preload, low cardiac output due to low perfusion, reduced oxygen delivery down to cardiogenic shock, and then subsequent death. When we're looking at the imaging of a CT scan, and this is a slice from the pulmonary embolism section on the Royal College of Emergency Medicine Learning website, you can see where there is no contrast here in the pulmonary trunk, as seen by the arrow, and this represents a massive PE on CT-PA scan, or CT pulmonary angiography, which is a gold standard diagnostic test for PE. When we have a look at echo studies, you can see in the box you have a patient who has massive PE. You can see that the right ventricle is enlarged and pushing on the right ventricle, and so there'll be high ventricular pressures. And then we look at after a patient who's been thrombolized, you can see that the right ventricle has normalized in shape and is of similar proportion to the left ventricle, because usually of course the left ventricle should be bigger, and the fact that the obstruction and the rising pressures in the right ventricular system then will cause low left ventricular output failure. And so you can see that this patient has responded nicely to thrombolysis, and that the ventricular pressures have been reduced in the right side. PASAC stands for parasternal short axis, and this is a slice that's taken in echocardiography. So clinical presentation of PE is often non-specific. Patients will often present with shortness of breath, chest pain, sometimes a pleuritic angina like in right ventricular ischemia, pre-syncope or syncope, and again it's important consideration of course of syncope, as it's seen in about 17% of patients, or hemoptysis. Now, hemodynamic instability for the purposes of this talk is defined as a systolic blood pressure of less than or equal to 90 milligrams of mercury despite fluids, persistent hypotension, evidence of end organ hypoperfusion, and this will often be evidenced by a rising lactate. So when we look at some data from the Academic Oxford University Press, these are some of the common symptoms that you can see for in confirmed and not confirmed PE. So you can see that shortness of breath will appear in about 50% of patients, but obviously shortness of breath is a common presentation. Pleuritic chest pain was a little bit more specific for pulmonary embolism. Again, cough similar on PE and not PE. So the more specific ones are signs of obviously DVT. Hemoptysis again is only marginally better than in the non-PE cohort. Fever, chest pain, and cough is the same. So you're really on the lookout for pleuritic chest pain as a good indicator of possible PE. So it's important that you are mindful that a lot of these symptoms are common in PE, but they're also common in other respiratory presentations of acute illness. So in terms of our initial assessment, so obviously we follow our ABCDE approach. Hypoxia can be quite common, or a type 1 respiratory failure, but saturations can be normal in up to 40% of patients presenting with PE. You can of course have hypercapnia from hyperventilation. The chest x-ray is often abnormal but not specific, and the role of the chest x-ray primarily in pulmonary embolism is actually to exclude other causes or find another cause which may be associated with PE, such as a lung malignancy. The most common finding in pulmonary embolism on an ECG is mainly tachycardia, and usually that's sinus at about 40%. The S1Q3T3 phenomenon may be seen in massive PE or right bundle branch block, or you may see partial right bundle branch block as well. So this here is a wedge infarction, as you can see inside from the triangle. This is a patient that's had a PE and subsequently developed a pulmonary infarction. There are no other findings on this chest x-ray. When you're looking at evidence of right heart strain on an ECG, you may be looking for the S1Q3T3 phenomenon. And this represents S waves in lead 1, Q waves in lead 3, and inverted T waves in lead 3. The most common finding, as I said, though, is sinus tachycardia, and the S1Q3T3 phenomenon is relatively rare. So when you're going to think about risk stratifying your patient, which is an important part of your clinical assessment, then there are a number of rules that you can use to determine the likelihood of PE. So the first one is the Wells score, and this basically looks at clinical signs of DVT, gives you a 3, previous DVT, active malignancy, hemoptysis, surgery, and tachycardia, and basically the higher the score, the more likely it is that you have a pulmonary embolism. So for example, if you have a clinical probability from a Wells score of greater than 3, so for example, the patients had got a clinical signs of DVT, has hemoptysis, active malignancy, and a tachycardia, then that would give them the high probability of PE. You also have the revised Geneva score, and again similar risk stratification using fairly similar criteria as to the Wells score, except it introduces age, and also it slightly narrows down for heart rate as well, and also includes pain on lower limb deep vein palpation, unilateral edema, which gives a score of 4, and a high probability of PE is seen in those who have a score of 11 and above. So you can also apply the PERC rule. Now the PERC rule is for low-risk patients, and this is to rule out the likelihood of pulmonary embolism. So this is if you're seeing a patient in the emergency department, you're fairly sure that there is no PE, then you can use the PERC rule to help you with this. And so you have to have all or absence of all of the 8 variables. You have to be less than 50. You have to have no tachycardia, you have to have normal saturations, you have to have no hemoptysis, no exogenous estrogen use such as the HRT or the pill, no prior VTE, no surgery or trauma within the past 4 weeks, and no unilateral leg swelling. So often people will request a D-dimer test, and again, whenever requesting any test in clinical medicine, it is important that you understand why it is that you're wanting to do this test. Now, it's important to note that specificity of D-dimer in suspected PE does decrease steadily with age to about 10% in patients who are age 80, and so this has partly led us to use an age-adjusted cutoff. And this is where basically the age-adjusted cutoff is the age times 10 micrograms per litre for patients aged greater than 50. So, for example, if you have a patient who's 80, their cutoff D-dimer becomes 800 rather than often the standard 250 or 500. So, and this can be quite useful in helping us to risk stratify and avoid us over-investigating and giving the risk of contrast to patients that don't actually need imaging. Now, when we look at imaging, we have two main options, and they include CTPA and VQ scan or nuclear medicine scans. Now, CTPA, the strengths are it's available 24/7, has a high accuracy and low rate of inconclusive results at about 3 to 5%, and can, of course, provide alternate diagnosis. There's often a short acquisition time and can give the right ventricle to left ventricular ratio, which, as you saw on the echo slice, is quite important when considering the need for thrombolytic therapy. Weaknesses are, of course, is that there's radiation exposure, there's exposure to iodine contrast, which has some risks in pregnant and breastfeeding women, and is contraindicating severe renal failure. There's also a tendency to overuse CTPA because it is available 24/7 and highly accessible and tends to be reported quickly. The radiation is about 3 to 10 millisieverts, which is a significant exposure to the young female and breast tissue. VQ scans or nuclear medicine scans, on the other hand, have almost no contraindications, but do have a binary interpretation. So either it is likely the patient has a PE or they don't. The weaknesses in nuclear medicine scanning is it's not available in all centres and often only available in daytime and weekdays, and has a high inconclusive rate, although this does depend on the nuclear medicine radiologist that is interpreting the VQ scan. Cannot provide alternate diagnosis, and on the whole you need a normal chest x-ray depending on the scanner to provide an accurate answer. So in terms of investigating and treatment, so this again is from the European Cardiology Society, but you have a suspected PE without shock or hypotension, then you ideally want to assess the clinical probability of PE, such as using rule out using PERC or consider Wells or Geneva scores. If there is a low or intermediate clinical probability, then you can perform a D-dimer, and if it's negative, you can discharge the patient. If it's positive, you can then proceed to CTPA. If there is high clinical probability or PE likely, then you should just proceed to CT angiography. The D-dimer is likely to be positive, and it shouldn't necessarily change what you would do anyway. So D-dimer really only has a role if it has a low probability or an unlikely classification with PE. So again, using D-dimers in patients unselectively will often cause more aggro than is necessary. So again, you want to be careful about the role of D-dimer. If there is shock or hypotension and you're able to get a CTPA, then obviously the patient should have an emergency CTPA and then confirm the need for primary perfusion or thrombolytic therapy. If not, then you consider requesting an emergency echo in which you can identify signs of right ventricular overload. And again, you can consider thrombolytic therapy if you have evidence of right ventricular overload and the patient's unstable, or there's evidence of hemodynamic instability and a positive CTPA scan. What's important to recognise is the majority of PE comes from a DVT, and that's often shown at about 30 to 50% on Doppler ultrasound. You do a Doppler of both the groins and popliteal fossa, and that has a sensitivity of about 41%, but a specificity of 96% for PE. So in terms of your post-diagnostic risk stratification, then you can use what's known as the Pulmonary Embolism Severity Index, or PESI. A simplified version basically gives you 1 point if age 80 and above, and that basically carries a 30-day mortality risk of 10.9%. Or if there are 0 points, it has a 30-day mortality risk of 1%. And you can see also that you have another version. This is age original version here, and you basically add up to numerous points and gives you more classes to give the patient their likely mortality risk. So elevated troponin levels, so often when these patients present to the emergency department with pleuritic or cardiac sounding chest pain, they'll often have a troponin test done as well as a D-dimer, and elevated troponin levels may be associated with a worse prognosis in the acute phase of PE, and therefore urgent echocardiography should be requested. Elevated BNP levels reflect the severity of right ventricular dysfunction and compromise in acute PE, and this is due to right pressure overload, which then causes the release of the BNP and troponin. This just summarises how you determine whether a patient is high risk or not, and that's obviously with the presence of shock or hypotension. And this is defined as systolic blood pressure of less than 90 millimeters of mercury, or systolic pressure drop by greater than 40 millimeters of mercury for over 15 minutes, if not caused by any other cause. So the acute management of PE is to administer oxygen if the SATs are less than 90%. Mechanical ventilation is high risk due to the pressure changes in the chest and the likely cause to precipitate hypertension. You should be cautiously fluid loading these patients, again being mindful of the risk of right ventricular overload, and administer a stat dose of low molecular weight heparin. Ensure the patient is weighed, not on anticoagulants already, or on dual antiplatelet therapy. A senior decision maker may give a bolus dose of IV heparin in high risk PE. If there is a high or intermediate probability of PE, then you should start anticoagulation whilst awaiting tests, or commence a DOAC. And it's just a good practice point to remember that the reason that people often get stat doses of low molecular weight heparin as opposed to being commenced immediately on DOAC is that DOACs should, similarly to warfarin, should have patient drug counselling. DOACs are preferred over vitamin K antagonists such as warfarin due to the less occurrence of interactions and the lower risk of major bleeding. Typical doses of low molecular weight heparin include tinzaparin 175 units per kilogram once a day, dalteparin with 100 international units per kilo every 12 hours or 200 international units once a day. Enoxaparin again is about 1 milligram per kilo every 12 hours or 1.5 milligrams per kilo per day, and each trust that you will work in will have its own different prescribing policy. So when comparing the warfarin and the DOACs, there are some obvious advantages and disadvantages of each. So in drug interactions, warfarin has many, whereas DOACs only have fewer, with some interaction with CYP3A4 and P-glycoprotein inhibitors. Warfarin advantage perhaps being once daily dosing, whereas DOACs are often prescribed once a day, such as apixaban and dabigatran. Dietary restrictions require consistent level of vitamin K intake in warfarin, but none in DOACs. The onset-offset time in warfarin is slow, whereas in DOACs it's quicker. Reversal agents, however, are well established in warfarin, such as vitamin K and prothrombin complex concentrates. There is a monoclonal antibody for dabigatran, but these are extremely expensive, and so reversal agents in DOACs is largely at the moment limited to vitamin K, PCC, and other medications as guided by hematology. So these are a prescribing table of the NOACs. Just to note that both dabigatran and edoxaban require 5 days of bridging with low molecular weight heparin. So the emergency management of pulmonary embolism includes intubation, although as I said this is risky, thrombolytic therapy with a drug such as alteplase, vasopressor therapy which will increase the blood pressure by reducing peripheral vascular resistance, ECMO or extracorporeal membranous oxygenation, percutaneous catheter-directed treatment, which is something we can offer here at the Royal Free, surgical embolectomy and vena cava filters, and anticoagulation. So when thinking about giving a thrombolytic therapy, absolute contraindications include a history of hemorrhagic stroke or stroke of unknown origin, ischemic stroke in the past 6 months, brain tumour, major trauma, surgery or head injury in the past 3 weeks, active bleeding and coagulopathy. Relative contraindications to thrombolysis include TIA in the past 6 months, already anticoagulated, pregnancy or 1 week postpartum, non-compressible puncture sites, traumatic resuscitation, refractory hypertension, advanced liver disease, infective endocarditis, and active peptic ulcer. So when dealing with the cancer-associated PE, then obviously it's important to know the type of cancer, such as whether it's gastric cancer, again, because this will influence your decision with regards to what is the safest anticoagulant. Low molecular weight heparin has been the standard of care, and that's because of a decreased risk of recurrent VTE and similar bleeding profile, and you treat the patient for about 3 to 6 months and beyond. You would consider edoxaban as well after some bridging low molecular weight heparin, and after 3 months you'd assess the risk and the likelihood to continue long-term anticoagulation depending on the prognosis of the patient's cancer. To discuss PE in pregnancy, there is a very good what's known as green top guidance, and these can be found at www.rcog.org.uk, and you can go to green top guidance. Long-term complications of PE. Well, PE has a variable prognosis. It's important to note that untreated PE has a mortality of 30% versus up to 11% those who are treated. There is a rate of recurrence which is significant at 30% at 10 years, and that's why a lot of patients will often go on to long-term anticoagulation. There's also a risk of chronic thromboembolic pulmonary hypertension, increased risk of cardiovascular events and atrial fibrillation, although predictors of reduced improvement include female sex, higher BMI, prior lung disease, and higher pulmonary artery systolic pressure on echo. So in summary, here are my key messages for recognition management of PE. First one, in a patient presenting with hemodynamic instability, you want to arrange bedside transthoracic echo. Number 2, if you suspect PE, initiate anticoagulation therapy unless the patient is bleeding or has absolute contraindications. Number 3, use recommended, validated algorithms for PE, clinical probability, and D-dimer testing. If the CTPA suggests single subsegmental PE, discuss the findings with your senior and the radiologist. In stable patients, ensure PE is confirmed, then assess the risk with TTE or transthoracic echo, BNP, and troponin. In high-risk PE, thrombolysis should be considered or a plan for if when the patient deteriorates. Number 7, prefer anticoagulation with DOAC over the low molecular weight heparin vitamin K antagonist regime unless contraindicated. With the exception of a clearly provoked and temporary risk, there is a lifetime risk of recurrent VTE. Patients should be reviewed in clinic at 3 to 6 months. So here are some resources for you. So this is from the Royal College of Obstetricians and Gynecologists, the European Society of Cardiology. There's a good e-learning module on the Royal College of Emergency Medicine, and there are also nice CKS guidance on PE. Thank you for listening, and as always, if you have any questions, you can email them to me, comments or feedback at james.piper@ucl.ac.uk. Please don't forget to like or subscribe to the Acute Medicine YouTube channel. Thank you very much. Bye-bye.